What if the future of addiction treatment isn't just about sobriety, abstinence, but about restoring the whole person? I'm Dr. Arwen Podesta. I help addiction professionals improve patient engagement and recovery outcomes using integrative, evidence-based strategies. And in this video, I'm sharing the tools that make that possible. Let's look at what the 2025 Functional Addiction Protocol could and should look like. For decades, treatment's been fractured, parsing out different parts of the body and brain in silos. One part of treatment addresses cravings, another manages trauma, a separate team might adjust the medications. Maybe if we're lucky, a nutritionist gets a little time with a patient somewhere along the line. It is well-meaning, and it's what the system created and allows. But let's be honest, it's also fractured. And in that fracture, we lose people. They fall through the cracks between the detox and withdrawal management, between therapy, between the medication plan, missing lifestyle support, between the diagnosis and really the full human experience. What we're left with is a patient who might look compliant or adherent on paper, but isn't thriving. They're maybe doing the steps, they're in therapy, they're showing up, but they're still dysregulated, they're disconnected, they're discouraged. And that's the problem. When we treat addiction as a symptom to suppress instead of a whole system to restore, we miss the very thing that is truly required in recovery: integration. This fragmentation doesn't just make our jobs harder, it actually predicts relapse. Because the carer isn't cohesive. If that's the case, the patient can't be cohesive either. And that's why we need a new protocol. One that looks beyond the diagnosis and starts asking what's really going on in this person's system. That's the shift we're making today. Let's say you're working with a patient, mid-30s, stable on medication, engaged in group therapy once a week, checking the boxes. On paper, looking good, but in the room, something feels off. Maybe he's agitated. You find out he's sleep deprived. He says he's doing everything right, but he still feels like his skin is buzzing. His blood pressure's climbing. He's snapping at coworkers, extreme irritability for seemingly no reason. You might adjust the medications a little bit, add a second group, refer him to a different type of individual therapy. And yet, you've made some changes, but 2 weeks later, what if he's worse? And his cravings are back. We're at a tipping point ripe for relapse. He has no motivation, he starts ghosting his appointments, and he drops out. And honestly, it's probably not because he didn't want to get better. It's because treatment didn't reach the level of his dysregulation. We mostly focused on the behaviors, but we missed the biology. We offered coping skills, but skipped the system scan. The patient didn't relapse because he lacked willpower. He relapsed because the care plan couldn't contain the complexity of what he was carrying. And if you worked in addiction a long time, you've seen some version of this over and over. And you know that's not patient failure, but it is a failure of something. That's a model failure. So what went wrong? It's not that you didn't care. It's not that the patient didn't try or want it. It's that the entire approach was aiming at symptoms instead of systems. Addiction's not just a pattern of behavior, it's a full body dysregulation, neurochemically, hormonally, inflammatory, and psychological, all happening at one time. And we micro-isolate one part of that system and actually call it treatment. We're still only addressing a fraction of what the load they are carrying. And that's why functional care is different. Functional addiction treatment starts with the question, what is driving this person's dysregulation? Not just what they are doing, but what's happening underneath. We look at what pathway might be driving their use, why the drug of choice is really actually their most effective reward. We dive into sleep cycles, cortisol rhythms, gut-brain axis, micronutrient load, trauma history, attachment patterns, all of it. Because it's all part of the story. And when you start connecting those dots, something powerful happens. Patients stop feeling broken. They start feeling understood. They start feeling well. And the treatment finally starts working with their systems instead of against them. It's not about throwing out what you're already doing. It's about really widening the lens. Functional care doesn't ask you to choose between medication or mindfulness, or between science and trauma work. It says we need it all. We need all the tools in the toolbox, and we need to know about them all because every individual is different. And recovery isn't a single path, it's a full map that might be different for everybody. Our job is to help the patient read the map. This is how we move from compliance or adherence to connection. From why did they relapse to how can we regulate the system before it breaks down again? And that's the powerful shift from fragmented care to functional care. And now I want to show you how to actually build that shift into your treatment model without needing to overhaul your entire program. Before we dive in, let me ask you something. In your own work, do you see fragmentation showing up? And if so, where might that be? Is it between medical care and therapy, between lifestyle changes and medication management, not having a nutritionist or acupuncturist or other type of subspecialty to refer to, or is it somewhere else entirely? Drop your thoughts in the comments. I really want to hear what you're noticing because that's where these changes matter most. Now let's talk about what this actually looks like on the ground, because I know what you might be thinking. That sounds great, but I don't have time to become a functional medicine doctor. You don't need to. You don't need to overhaul your program or add 15 new positions or send your team back to school. You just need to realign your lens a little bit and make a few intentional shifts in how your care is structured. So let's walk through the system. Start with root cause mapping. That means that just during the intake, go beyond just the standard checkboxes, asking not just about substance use history, but why do they like one substance versus the other? This can give you a roadmap of the pathways that can be enhanced. Ask what's driving their inflammation. Look at sleep quality, gut issues, trauma history, hormone disruption, micronutrient status, not in a super lab heavy way, but in a pattern seeking way. And from this, you're mapping the internal terrain. Now, you don't have to do this all on the first visit because it can be a lot for a patient that is in early recovery or not yet in recovery. But build this idea of thinking into your getting to know the patient. From there, build in integrative and collaborative practices. If you're in a setting with an in-house team, build in teams around it. I'm not talking about a 3-hour committee meeting every Tuesday. This can be just a short huddle, maybe weekly, where a nutritionist, therapist, prescriber, and case manager maybe compare notes. All talk about how to help the patient together. The goal isn't complexity, it's coherence. And if you're siloed and solo, have connections in the community where you can easily collaborate, have releases of information, and use them. Next, use structured psychoeducation. I don't mean handing out another brochure. I mean giving your patients an actual map of their brain and body connection to help them and their families understand why they're waking up anxious, why their cravings spike at night, why they feel flat, even though things might be fine. And when patients understand their system, they can start regulating it. Finally, integrate physiology with psychology. And this is where the magic happens. Pairing cognitive work and somatic practices, supporting liver detox while working on trauma processing, encourage breath work alongside medication management. It's not either or, it's both. And the truth is, when your care team starts speaking a shared language, when you treat the body and mind as one system, stop chasing symptoms and start building stability, that is what whole person recovery actually looks like. And once your system's aligned, patients really do feel it. They stick around longer, they engage more deeply, they relapse less. So let's zoom out for a minute, because what we're really talking about here is a shift from really fragmented treatment that chases symptoms to whole person functional care that restores systems. And when you make that shift, you start to see the difference. Patients stop bouncing in and out of care, the revolving door stops revolving, patients stick. Staff actually has less burnout from chasing behaviors that never resolve or from doing admission after admission because patients keep leaving and spots keep opening up. Your program stops feeling like a triage center and starts functioning like a recovery ecosystem. This is what I want 2025 addiction treatment to look like. This is the protocol that it's calling for, not because it's trendy, but because it works. And it's not about being perfect. It's about being aligned with how the brain, body, and behavior actually function together in real life. So now you may be thinking, well, what's something I can do right now to strengthen client engagement? I've got you. Head to my video on neuroscience hacks that build patient trust quickly. It's one of the most practical tools you can use to strengthen engagement, and it pairs perfectly with the strategies we covered today. Recovery doesn't have to be chaotic. Treatment doesn't have to feel disjointed, and your program doesn't have to settle for good enough outcomes. Whole person care shouldn't be a luxury. It isn't a luxury. It is the new standard, and you're already on your way. I'm Dr. Arwen Podesta. Thank you for watching, and thanks for what you do.